Today's speaker is Dr. Kathleen Blake, who is the Vice President of Healthcare Quality at the American Medical Association. Dr. Blake will be presenting on what makes a high-performing practice. Dr. Blake, thank you so much for being here with us today. I'm going to go ahead and pass off the virtual mic to you.
That sounds great. Thank you, Brittany. And certainly we've been looking forward to being able to share with you some of the work that we are doing to answer the question that you see here of what makes a high-performing practice, and really with particular attention and focus on high-performing private practices. And if we could step back just a bit to what is the role of the AMA in the AMA, or really in the professional environment for physicians. And we see ourselves as your powerful ally in patient care. And we do this in many ways, but the three that are the focus of this presentation today and of much of our work in our strategic arcs at the AMA are: number one, removing obstacles that interfere with patient care. Second, leading the charge to confront today's public health crises. That particular commitment preceded the COVID-19 pandemic, but of course is front and center with all of the work that we do. And then thirdly, restoring the joy, the meaning, and the purpose to the profession. And so to just give you a quick preview of today's program, I'll be reviewing the work that we've done to better understand the private practice landscape, but really you will see that much of this applies to all practices. In the course of doing that review, one of the things that we learned was that there was no clear, mutually agreed upon, consensus-based definition of what constitutes a high-performing practice. And I'll give you a bit of a preview to some research that is ongoing that we have been doing, where we've done deep dive interviews with physicians in private practices across the United States to ask them, what does success look like to them, and what is needed to ensure their success long-term. That will then be followed by a conversation with Dr. Jasser, who is the chair of a new section at the AMA, which is the private practice physicians section. And so he'll share his thoughts about the presentation that I will give right before, and he'll also introduce you to the work of this section. And then, as Brittany mentioned, we'll have the Q&A. So one might say, why is there this enhanced focus on private practice at this point in time? And I think really the clarion call was that in 2018, for the first time, fewer physicians in an AMA physician practice benchmark survey reported owning their own practices than were employed. The second factor is really the hospital acquisition of practices, and starting to see some of the research findings saying that what had been anticipated to be one of the benefits of that hospital practice integration, you might say, one of the benefits had been expected to be improvement in the quality of care, but actually the reports started to show us, and all the citations at the bottom of the slides, that we weren't seeing the improvements in patient experience, and that we weren't seeing any significant changes in readmission or mortality rates. So some of that return on the investment in change was not being realized. We started also to hear reports about how access to care was being reduced, sometimes lost altogether, if practices that had been acquired were relocated to perhaps more difficult or more distant places, or if the practices themselves had shuttered, had stopped delivering care. And then with some of the work that the AMA has done, looking at major, not just horizontal, but vertical consolidation, there has been concern that as the markets have consolidated, that there may be a loss of the competition that can be a driver, a motivator to improve quality and to lower costs. And specifically, that the enlargement of integrated health systems may raise the cost of care in the markets in which they operate. From the patient standpoint, on the right-hand side of the slide, also more patients than ever. October 2015 to September 2019, we're saying it was difficult for them to find a doctor who they could see for their care. Couple of other thoughts that came out of our research into what's going on in the environment is the one which is, what happens once an independent practice closes its doors? It is difficult to replace it or reopen, shall we say, those doors. You've lost something by the closure. The second thing was the loss of what we might call linchpin independent practices. So these are practices, it might be in a community that it's obstetrical and gynecologic care, care for children, emergency services, surgical care, where those linchpin practices that were integral to the whole critical mass of delivering services were being lost. And that the loss of those practices meant that physicians had fewer practices to choose from, and therefore might find themselves in circumstances where they had less professional autonomy, and that less professional autonomy has been shown to be associated with lower levels of professional satisfaction. Similarly to physicians, when practices close, the choice that patients have is diminished about where and from whom they receive care, because perhaps the loss of those linchpin offices, and that can reduce patient satisfaction. And particularly we're concerned about what's happening in rural and frontier communities and the effect of that loss of competition. Some of the what we might call social demographic changes in the practice of medicine may also be affecting people's choices, particularly as they graduate from medical school and complete their residencies and fellowships, their choice of practice settings. And one, and I am amongst them, the rising percentage of women in medicine means oftentimes that you are trying, an individual doctor is trying to find a location where their two-career couple can find two good jobs. And that tends to favor the larger urban institutions just by virtue of the number of opportunities that they are able to offer. And two-career couples are making trade-offs, and we've seen this certainly during the pandemic. The trade-off of money and time and risk-taking. And so think about the couple that may be coming out with double dose, so to speak, of their educational loans, debt burden, and if they combined have those heavy burdens, their willingness to take risk may be less than if they do not have debts or if only one member of the couple does. The other thing that I think many of you are well aware of is that there are more practice options now than perhaps 20, 30 years ago, which is, for example, hospitalist practices in large health systems, no longer limited to just primary care, but also extending to other specialties. And it's those practices, because of their size, that are oftentimes able to offer salary guarantees, more predictable schedules, and the promise of greater work-life balance. Again, some trade-offs. I've talked already about high medical school debt. And then interestingly, as we've started to do some research that I'll describe a bit later, there is this challenge of what are you exposed to in the course of your undergraduate and graduate medical education? Are you only in a large integrated health system? Are you only in a community environment? What you see and the people who inspire you can have a very great influence, a very strong influence on the type of practice that you choose for yourself, and can have some considerable impact on how comfortable or uncomfortable you might feel about managing the business aspects of a practice. And then with the move towards value-based care, participation requires investment. And that's investment in infrastructure, which might be the electronic health record system that allows you to do quality reporting as a group. You may need sophisticated management to be able to work with a multidisciplinary team and be able to negotiate contracts. And depending on the services that your practice offers, you may also be seeking highly trained personnel to work with you as part of a team-based care model or to provide technical services. So what about life after medical school and residency? And these days, the default selection of practice setting for medical graduates, people coming out of their residencies and fellowships, is to be employed by a health system for some of the reasons. That's what you're exposed to, that's what you know best, and feel most comfortable that you know what you are getting into, and increased opportunities for that kind of direct employment. Studies have been done to ask medical students as they approach graduation where they feel confident and where they are less confident in terms of their medical practice. And they express fairly good levels of confidence in their clinical decision-making. They also know that they'll be going into environments where they will be working with others who are ahead of them and with faculty running that residency program, but they have less confidence about the business aspects of medical practice. And then lastly, many so-called millennial physicians are starting to paying more importance to work-life balance. And they're concerned about their ability to be able to achieve that balance. It's not that this is all, we might say, just coming from the physician perspective. The insurance industry very much focuses on physician practices from whom they purchase services. And increasingly, with United Health Group and Optum being a good example, are owning or becoming very closely affiliated with physicians. Private equity investment is rising in prominence with independent practices. We think that now is a factor or a model for about 4 to 5% of physicians in America. And the numbers here speak for themselves in terms of how many practices, how many deals, and at what dollar value have been executed, comparing the early 2010s to more recently. Hospital acquisition of practices has certainly risen. It's doubled for the most recent data we have between 2012 and 2018. There are more and more organizations cropping up that provide practice management services. And then with the COVID pandemic, we've seen a level of instability in practices like has not been seen, I would say, ever before. So we asked the question, and I apologize, this is a bit of an eye chart, so I will go through it in some detail, of really what makes a high-performing physician practice. And what you see under this umbrella is the results of brainstorming, interviews with AMA leaders, interviews with our unit's physician advisory committee. And what we were told, the top line items, the ones in bold, were the most prominent. Practice design. What are the internal arrangements and decisions? And then the culture and the leadership model that was being adopted. I will tell you here, there is no one size that fits all, but that a favorable practice design, a positive culture, and strong leadership make all the difference. Some of the other factors I think are fairly self-evident: staffing and training, the ability to recruit and retain staff, pay wages that are competitive in your marketplace, execute on contracts that are well understood and will contribute to sustainability, and then a lot of technology and process improvement capabilities. Market characteristics have to do with perhaps factors that are not as much under your control, but you have to have that market intelligence to be able to be competitive and to be able to see that you will have access to patients. One of the strategies that we've seen is this diversification of revenue, the so-called don't have all your eggs in one basket, because if one source of revenue becomes unstable, other sources can potentially make up that difference. And being able to see, are you able to recruit staff? Is there, let's say, a nursing school, a medical school, medical assistant, educational programs, things like that. And then environmental factors have to do with just the health of the local economy. The local demographics determine what kinds of needs your patients will have. We all know that physicians practice in environments that can be quite different based on local, state, national laws, regulations, and policies. So our ongoing research is to really understand and to inform our efforts to support physician-owned practices. And some on this call, at this webinar, may say, but wait, I'm in an integrated practice environment, a health system environment. How could this relate to me? Well, a bit of a preview of what we think will be some of the learnings are that many of the challenges that were identified are shared. They aren't unique to a physician-owned practice, but our perspective for this particular tranche of research was to say, the practices that may benefit the most from the work of the AMA will be the smaller practices, those that are physician-owned and that do not have access to the kind of capital, technical resources, and management resources that are enjoyed at an integrated health system context. And so we defined the high-performing physician practice based on high performance in the MIPS program run by CMS. And we did so because that allowed us to look across the nation at participants in MIPS, of which there were many, and we set the threshold for high performance at the MIPS threshold level, meaning a practice was bonus eligible. So for the latest year that the data was available, that meant that they were at 70 points out of 100 available points on the MIPS score. We focused on practices between 1 and 15 physicians. We did so because we said, at that size, we're going to see and be interviewing physicians who are, most of them, and they proved out to be, really knowledgeable about their practices and what were the challenges that they faced, what were the solutions that had worked, and what were the benefits and the risks of being in that environment. We wanted to look across the country, multiple geographies, and we could not look at every specialty. So we chose primary care, multi-specialty practices, cardiology, because it's a mix of both ambulatory medicine and procedural, and general surgery. And we asked practice leaders about the external environment, the internal factors, and about their leadership and their culture. These are just some of our early observations. What was fascinating was that many of these physician leaders at these practices, which are externally defined as high performing, they didn't actually see themselves as such. And maybe that's some of a doctor's natural anxiety, where you always want to improve, you always think that you could do better. Or sometimes you're just working so hard that you don't notice that. But what they did comment to us is that, especially in the smaller practices, there are times when they can feel a bit invisible, that they don't have perhaps the same ability to go to conferences or to participate at a national level. And so addressing some of that feeling that can sometimes arise of professional isolation looks like something we might be able to work on with them. The other thing we are finding is that the erosion of private practice, it's not an individual failure, it's not an individual's problem. It really is a systems problem. And that the challenges they face really reflect deep, long-standing systems issues with the practice of medicine. And so then what they told us they wanted the AMA to help with, they said, let's start from the get-go. We need to be able to recruit talent into our practices. And we need to overcome that visibility problem, because young physicians cannot choose what they do not see or know. They wanted also for there to be a more structured way, a less ad hoc way to educate future physicians in the business aspects of medicine. And they were committed to continuing the clinical mentorship of young physicians who came to join their practices. But the business mentorship maybe has been less focused on, but there is a path to doing that. Physicians wanted help with negotiating contracts and securing fair payment. And certainly AMA has seen and heard about this, as physicians who have talked with us about behavioral health integration have done exactly that, renegotiated contracts and securing payment that will cover those services. And then most, if not all, of these physician practices have electronic health record systems, but they all realized that they were not taking full advantage, fully leveraging the strengths of the technology. And what we also learned from them was that the AMA, if we are able to help these practices, that we will be able to help all practices. There isn't one size fits all. These are shared challenges, and that our motivation behind doing this work is to go back to the statistics. Private practice of medicine continues to be a large, very important part of the healthcare delivery landscape. So what would success look like? Increased physician satisfaction, practice sustainability. That's actually the name of the unit that offers these webinars that I am part of. That physicians have the information they need to choose the setting and the model in which they practice, so that it's not as though there is overexposure to one model or another, but that there is informed exposure to the full range of models. That then means that there is some patient choice of the physician, the practice, the setting in which they receive care. We think in the long run, what will also be a measure of success is when we start to see that the mean tenure of the physicians in the private practice models stays steady or increases. And I would add to that also the ability to have succession planning and to be able to recruit on a consistent basis the next physicians who will be caring for your patients, perhaps even for you. And then also that there will be, I think, ways that private practices contribute to the fulfillment of the quadruple aim. And so with that, I thank you for your attention, and we will switch over just momentarily to really hearing the response from Dr. Zuhdi Jasser to what's just been presented. Dr. Jasser is an internal medicine specialist. He practices in Arizona, and he is also, and he will talk with us about this, he is also the chair of the newly established AMA section for private practice physicians. So, Dr. Jasser, thank you so much for joining us today.
Thank you, Dr. Blake. It's great to be with you, and I want to thank the AMA for covering this in your webinar. This is something that so many physicians feel passionate about. And as Kathy mentioned, I'm in private practice with 3 providers in my practice. I've been in private practice since I left the Navy in the late 90s. And, you know, for some of us in private practice, it's sort of in our DNA. And I think, you know, as a delegate from Arizona to the AMA, which I've been since 2008, I, you know, realized that organized medicine is a key to our success. And I can tell you that part of what the AMA is doing, as Kathy laid out, is providing diversity in the practice of medicine. And many folks, you can, and I'm going to give you sort of my assessment of what she went through as far as data is concerned. But again, that's my perspective. It's only my views. I do think that if you're passionate about private practice, it doesn't mean that you denigrate the employed doctors or other models. It just means that's what we feel passionate about. I do think all of medicine suffers if private practice vanishes, if it's no longer an option. And I think that's sort of what the data laid out. So I've been in private practice for 20 years. We have a primary care model that has weathered the storms of the changes in Obamacare in 2008 to 2016 and some of the changes with ACOs, et cetera. I will say that if you look at the data, there's very little to disagree with. I think that if you look at what's been laid out, the reductions, the buying up of practices, we've all seen this across the country where the landscape around us, and I'd almost look at what you know, Dr. Blake went through as sort of a meteorological weather report about what happened in private practice. And that meteorological weather report may not change whether you live. Some people will move out of a state or move out of the, you know, hurricane areas or whatever it might be when the weather changes, but most people don't. Most people weather the changes and then adapt to it. So I can tell you that as far as the resonance is concerned, when you look at high performance, on the one hand, we did, you know, that data did look at MIPS and things that the government and insurance plans sort of label us as high performance. But many of you know that high performance is really what our patients think is high performance. And I think part of the appeal and what has left me in private practice, and you probably don't need me to tell you this, is that for most of us in small practices, it's not a transactional thing. We talk about work-life balance. I would ask all of you to look at the burnout data, even though you might poll many folks in private practice or not and say, oh, if you run your own business and you write your own checks, then therefore you probably are the closest to burnout. While we might feel the most frustration, you look at the data, it actually shows that even though our frustration levels might be the highest because we can barely make ends meet, especially now after a pandemic with the decreased throughput, et cetera, at the end of the day, having complete control of your schedule, of your EMR choices, of all of that has a huge difference in burnout data versus being an employed doc where you basically get told how many patients you have to see, sort of, are you more pilot or more airlines? Many folks feel that they just want to be a pilot to drive the airliner, and that's fine. That's, again, the diversity in medicine. But there are folks that want to be the airlines, want to be the business, no matter how stressful that might be. And we can go through in the Q&A as far as what I think makes life a little more peaceful in private practice. There's certainly been struggles, but at the end of the day, the currency, if you will, if you do it simply based on income and free time, it's been very tough to be in private practice. But if you look at the currency based on, the highs being higher, the lows are certainly a little lower in private practice, but the highs are higher, meaning that, I have so many patients that might go to large institutions and then realize they come back to me because the identification of their doctor as being their practice is a lot more astute and acute versus when they go to an institution where they might end up seeing you. Yes, they identify you as their provider, but the identification, and probably the key word I would want to end with in this sort of initial overview, is community. And that's, I think, why the AMA has reached out to make sure that we sustain small practices is, the AMA across the country and our organized medicine is dedicated to community. And if there's anything that's sort of the bedrock of community is your local doc. And I think ultimately, if you dilute your community, and that's really why I've been a small practice doc, is I sort of feel engaged to my community, be it the medical community, faith-based community, and whatever it is. And if you're going to be engaged in your community, yes, you can do that as an employed doc, but it is a lot harder. It is a lot harder to know sort of the lay of the land of where patients are and how patients are making choices, et cetera. So there's a lot of freedom that I think you have, even though it becomes more difficult to make ends meet when you write your own checks. We started the Private Practice Caucus in 2010 based on a resolution I submitted to the House of Delegates, and what I think is one of the most democratic bodies in medicine, which is the House of Delegates at the AMA. And slowly that sort of had a pilot project. We saw how it worked. It went from 10 docs to 50, and now it's over 200 physicians at the House of Delegates, which is over 1,000 docs total that are members of our private practice now section. And it deserves its own section. Why? Because there are two things. One is employed docs have institutions that can have their own advocacy arms versus private docs really are completely dependent on organizations like the AMA or your state medical society to be your advocates. Secondly, there is, because we've become a minority, just like any other minority section, there needs to be sort of a collective interest where we realize, many of us reinvent the wheel in a private practice from town to town to town. Why do that when you could pool your resources? And that was really the main goal of the private practice section. And it's very non-political. We have folks from various ideologies politically and what they think the solution should be. But the bottom line is that it's worked because we stay apolitical and look at what is the way to keep private practice viable for all of us.
So people, and hopefully you have seen me nodding and smiling because I ran a private practice and was in a private practice for 25 years. And it is that comment about the highs are higher, the lows are lower, I think is very, very true. What I also heard you say is such an important word, community. And that involvement in the community where you live and work is, we think, part of the secret sauce, you might say, towards professional satisfaction. I used to have people see me in the grocery store with my kids in the grocery basket, or they would see me at the soccer game. And there is something that is very affirming about that for them and for you. So if you had some key messages to share with this audience about what can the AMA do other than establishing the private practice section, other than being able to have people like you chair the section. Where do you think the AMA should focus its efforts to be able to make this a sustainable, satisfying model of care?
So a couple things. Number one is our community of private practice docs is a resource that I can't tell you the number of times docs from California, Idaho, Wisconsin, New York will chime in on things they're doing locally through our listserv, through our community in the AMA section that tells us about things that the staff may not have been attuned to that now they learn about and we can look to solutions about. So number one is just being engaged with the rest of a small practice. And how do we define small practice? We have two divisions. One is practices of 8 physicians or less, and the other is 8 to 50. And pretty much we focus on practices 50 or less. And your data, actually, we had that division before you got all the data. And the data you showed does show that that's pretty much a threshold. Once you get over 50, you start becoming more of an institution than a small practice. So that's number one, is community. Number two, I think the AMA can help us. You know, one of the things we are most sensitive to when you write your check at the end, right? You're in a small practice when you pay everybody else, all your expenses, all your employees, and then whatever's left, you pay yourself. So that the way you can become less stressed is by decreasing your expenses. And a lot of frustration in private practice is based on expenses. So what happens is EMR companies, unfunded mandates we saw through the pandemic, especially, there were some mandates that happened, and our state medical society did help with PPE and other things. So there are areas that are large ticket items that institutions can cost shift within their institution while small practices cannot, where the AMA, through its weight of reach through each state, et cetera, can help us collectivize, if you will, some of those costs that can immediately help our bottom lines and help our climate of practice. And I think third is testimonials. I think there's, you know, one of the things that people forget when you're by yourself and in this sort of a vacuum of your own practice as you're struggling to make payroll and other things, talk to folks that left the practice. I think data is going to show, and you touched, Kathy, about private equity buyouts and things like that. And by the way, that's not a black or white thing. There are various forms of it. I think you're going to find, and this is guessing on my part, the private equity joint investment processes in which the private practice stays intact with 51% control, et cetera, probably are going to be more successful than the ones sort of get bought out and then you become more of a pilot and less of the airlines, as I said. But having said that, at the end of the day, I think what we need help with, and I think in the community, is what are some of the behaviors that, you know, because what we have found is there's sort of a 3-year honeymoon where initially you get that initial increase from the buyout where you say, oh, this is so much better. I love having, you know, locked in hours and I can just focus on seeing patients. I get that. Most docs after 3 to 4 years start having buyer's remorse or seller's remorse and regret and want to go back because they realize they exchange one set of frustrations with the other, and the other set of frustrations they can't change because it's such a huge board of directors and others that they can't fix versus the ones they do have control of. So those narratives might prevent docs and also students, where we're talking in our private practice section where we're starting to engage medical schools and residents and fellows so that they realize. Right now, I think it's less than 8% are choosing small practices up front, and they're only doing so later. I think the diversity of choices out there, they'll realize that it's not just the institutions they can join, that there are many docs that will give them narratives and stories and testimonials that the AMA can collect and begin to educate that, hey, small practice might be something that you want to do. No different than the grocery store owner that decides, you know what, I'm going to own my own store rather than go try to work for Walmart or the larger stores.
So those are great suggestions for the AMA. I have been taking notes. The program is being recorded. And so actually one of the attendees asked the question, what's being done to share presentations such as this one to medical students? So certainly AMA has a vibrant medical student section. And so it is this kind of presentation that is made available to them. Another is, just as Dr. Jasser said, and more true when we can all meet again in person, is being able to share those stories and make those personal connections so that people say, this might be something that is right for me. I'm going to take another look or a longer look. Louise Andrew has a question for you. And Dr. Jasser, maybe you could tell us, how does an AMA member join the private practice physicians section and listserv?
So we will, and I'm not sure if it's up yet, but our section officially launches in the next few weeks. We have a launching webinar in mid-April. I think it's on the 11th on a Sunday, so join us for that. There'll be some advertisement at the AMA website for that. And talk to your state medical society about your delegates that at the House of Delegate meetings that meets in June and November. Can engage in the section, but you can engage in the section outside of the House of Delegates. So become a member through the website and engage one of the staff and just tell them you're interested, and you can be added as an AMA member to that section. We would love to have you, because right now, so far, it's really only been pretty much folks at the House of Delegates, and that's really why the section status will make us a lot more effective, because we'll reach out to folks that haven't been engaged through the House of Delegates, but rather through their own practices from state to state. And we really would like to get a better sense of what's happening out there, especially now post-pandemic. And by the way, this is not a post-pandemic evolution for the AMA. You can't just launch a section within 4 months. This has been 2 years in the making for the AMA through their Council of Long Range Planning, 5 years since we initially presented it to the CLRPD. So this has just happened to be a perfect timing as far as post-pandemic. There are some stories in the Washington Post last year, for example, in the summer, that 50% of primary care small practices would not be around. I think thanks to the AMA and some of the CARES Act and other things that did not come true yet, but we want to make sure we know across the country what are the stressors you have, so that the AMA can advocate and our section can advocate. We're coming up with resolutions for the June meeting, and if there are any things you want changed regarding policy, that the section's process of debating resolutions and passing them on to the House of Delegates will be a way for you to get your voice heard also.
So what I'm hearing is that even though sometimes the AMA can seem like a very large organization, and it now has about 255,000, yes, 255,000 members, that it can also be an organization that can respond to the needs of the members, to the ideas that bubble up. And that listserv, I would strongly encourage people to participate in, because, shall we say, that is owned by the participants. That is for
Absolutely.
them to be able to talk to each other and to say, have you seen such and such? Or how did you solve this particular problem? And I think the advantage of that, it goes to the comment I made earlier about feeling sometimes of professional isolation or loneliness. I can absolutely guarantee any challenge that someone brings up on that listserv, somebody else has experienced it, and maybe they've even solved it already. So we have another question, which is from Michael Raish, and I hope I'm saying your name correctly. And it is, would the AMA, so I think I'll take this one, be able to help form an independent practice association that would negotiate with payers on behalf of smaller private practices and increase our bargaining power? So I'm going to step back a bit from that to say that the AMA is a membership organization with a wide range of members. What we are able to do is provide toolkits, trainings, some workshops. So it is the to build the capacity and the capability of practicing physicians to, for example, look at contracts closely, understand the terms and conditions, be able to understand the long-term implications, financial and otherwise. So although we're not able to be that specific organization that represents you in a negotiation, where we do think there is a space is to be able to help practices know how to negotiate. So thank you for that question. There is a question, and maybe we'll have Dr. Jasser start with this question. I'll follow up if there's any need, but it comes from John Novick, who asks, what does one need to do or change to make a practice high performing? And certainly I could imagine this is a lifelong, or certainly one's professional lifelong journey. But Dr. Jasser, what are some of your thoughts about how practices can improve?
Yeah, so let me give you I think the more important part of this answer is high performing to me is, as all of you know, when you're enmeshed, embedded in a community, it's really related to your reputation and how your practice is perceived. And as many of you know, we do very little advertising in medicine. So the best advertisement is word of mouth. So I would think most of you feel, and I'm sure, as the questioner probably feels, is you're high performing when every new patient you have a certain number of new patients per month. And in those new patients, they see they were referred by other patients. So how do you do that? How do you maintain that customer service when you have to have a certain throughput and your turnover exists in staff and other things? And I would tell you is be transparent. I think it's amazing how much patients will tolerate wait times. They'll tolerate a number of things when you're transparent with them about the struggles you are going through and the staff is as you evolve and meet certain measures. And some of the patients get frustrated with some of the hoops they jump through for the annual wellness visits that we do and other things, and we just sort of transparently tell them. And other things is also be transparent with your partners. I can't tell you the number of practices that break up that I've known where there's not as much transparency either with some of the pre-partner staff or partner staff or whatever it might be, and they simply are given the information of what their pay is based on and not really a transparency of the stressors of what the practice is going through and not enough communications. So I think that's one of the keys I've found in retaining good staff and retaining providers that stay with you is you tell them, listen, this is the bottom line. These are the expenses we have. This is the reality of practice right now. And many of them are just unaware and they think the grass is always greener. They bring you data of average salaries, and those average salaries are based on a lot of different data that sometimes doesn't apply to small practices. And the currency is not always just simply annual salary. So I think the second most important thing I learned is transparency. And the other is also, sort of the comfort. I know many of us just want to see patients, but devote 10% of your time to understanding the administration, understanding what the measures look at, understanding how your EMR is culled by the insurance company when they see you. You might be doing all the colonoscopies and eye visits for diabetics, et cetera, but if you don't have the right box checked on your EMR, you won't get the credit for that measure to be rewarded as a high-performing practice. And that's one of my main struggles. So I'm reaching back to the AMA to say, how can we get better paid for the time it takes to get those measures? Because right now, one of the toughest things I find with insurance companies is there's such a long feedback loop of 6 to 18 months. By the time I get my incentive check, I don't know how to modify my behavior from 18 months ago. So we're trying to narrow that circle, and some of the plans are working more closely with us and bringing people into our office to quickly tell us how the data is circulating back. So that's the last hint I would tell you is it's sometimes impossible to get a hold of provider reps, but once you do, have them come in, meet with them monthly so that and your practice manager knows what the measures are, how they're looking at it in your practice.
So I think that's great, because what we've heard also, so I think sometimes there can be, shall we say, a love-hate relationship between the physician practice and the plans. What we're hearing, and just heard from you, and we've heard it from others, is that mutual dependency. The plan wants to be successful on the measures, those are HEDIS measures. The physician wants to be successful, and the patient, let's not forget the patient, wants to be healthy. And so that transparency, numbers are just numbers. Literally, the number of people who get the colonoscopy or have their mammography or have smoking cessation counsel, the numbers then help you tell over time how you're doing, whether you're headed in the right direction. And it can also, my own experience would say, it can be highly motivating for staff, because if they can see those improvements, then it's almost a virtuous cycle to be able to continue to improve. We do have a question here about, will the listserv be available to folks who support physicians in private practice? So I'm thinking these are the administrators and others, or just to the physician members in the private practice physician section?
That's a great question. I'm so glad that I got in this discussion, because I'll tell you, for example, in the Board of Trustees, every one of them in the AMA Board of Trustees supports us. Many of them are in private practice and are engaged very directly with us, and some are not, but yet want to support us. Our bylaws are very transparent. We are looking at how to identify the membership, but there will be active members, which are those which have 50 or less physicians in their practice, and then there'll be supporting members. Or associate. We didn't like the term associate, so we're trying to find a way, just like you said, supporting membership.
Yes.
Because bottom line is they're just like Dr. Blake, in private practice for 25 years. Once you leave it, you still are a fantastic resource for our practice. You want to see your legacy be maintained and not to see private practice disappear. So a lot of docs interested in legacy, a lot of docs interested in making sure their wisdom of the decades they've had in practice, or also who realize that competition is good. So even as employed docs, they want to see their own institution prosper through a climate based in competition, which I think is always good for the environment in which we live.
So you've touched upon the fact, and the questioner, I think, was also looking at that ability that one has to have, I think, to have allies or associates. I used to think of it almost as my kitchen cabinet, that there was a group of, for example, business attorneys in Albuquerque who specialized in helping advising medical practices. There were bankers who were particularly knowledgeable about the cash flow circumstances of practices. There were people who could tell us if an office space would be opening up that we might be interested in if we were adding new physicians. So the idea that you can do it all alone, well, maybe, but I would say there are people with specialized expertise who are there to be able to help you, in addition to the folks who are in your actual practice. So there's a comment, and this is going to be our last question, which is how would, and maybe the person meant to say, what would be the best practice for a private practice to fulfill the needs of an integrated healthcare system for the community we serve? So I think what I'm hearing is that how do the physicians in an integrated health system and in private practice work together for the benefit of the community and the people who live there? Dr. Jasser, that wasn't an easy question.
No, no, and I think that's evolving. I think one is to feel that, understand that the concept of the patient-centered medical home is and as a primary care doc, I've embraced it because I really feel it's just sort of reinventing what we've done in the last 100 years in medicine, which is to have your primary doc sort of be the quarterback of care. So that patient-centered medical home needs an integrated system. Right now, you have professions evolving that include medical navigators and other things because the system is so overwhelming for patients. So what we can do is integrate better because we can then allow the things we do best so that we operate at our license and not at sort of the tedium. If we operate at our license, then we can integrate better, utilize our resources more efficiently by knowledge and communication. That's one of the things I found that the AMA has helped me with and the section has, is learn how to communicate with the docs in my community, because that's one of the biggest challenges and why medicine is so fragmented is we don't even sometimes take the time that we need to talk to specialists about care, to learn what's happening at the hospital. Our lounge in the hospital is no longer really a lounge anymore because docs aren't really rounding as much, especially primary docs. So a lot of that I think can re-evolve through sections like this. And this is why I think it's filling a huge gap that's necessary. And last, I want to tell you one last thing, and I'll let us end on this, which is people say, what can we do about sustainability of practice? Try to diversify your own income, meaning that don't let your whole, as you said in the presentation, Dr. Blake, don't put all your eggs in one basket. So continue the contracts, et cetera. Start doing consulting work, other things outside your contracts, and don't be shy to work outside of sort of the old box so that you can continue to see patients at the tempo you want and have other profit centers outside of patient care, because sometimes that can not only be more rewarding, but give you more flexibility and maintain your private practice. So that's a little bit outside of the box, but I think it sort of looks at what a lot of docs are doing so that they don't have to shift into an employed model.
So Dr. Jasser, you have more than inspired certainly me. I'm sure that is true for our audience. We have a couple of questions that we'll keep track of, and we will be happy to answer them. But at this point, I want to say thank you. And I'm going to turn things over in the last minute to Brittany to close out our session.
Well, Dr. Blake and Dr. Jasser, that was certainly a wonderful presentation and great discussion. Thank you so much again for all of your time and expertise today. To our participants, thank you again for joining us. I realize we're at the top of the hour, so I'm going to go through this final information pretty quickly. For additional resources to support your physicians and care teams, please visit the American Medical Association website. Again, thank you for joining us today. We hope that you are all able to join our next upcoming presentation, which is scheduled for April 7th at 12 p.m. Central Time, which will feature Dr. Kevin Hopkins, who will speak on challenges to team-based care, COVID-19 and beyond. Again, for any questions that we were unable to answer today or for additional questions, please don't hesitate to reach out to us at action.labs@ama-assn.org. Thank you again for your time today. We hope to see you all again soon. Dr. Blake, Dr. Jasser, again, thank you so much for contributing your time to this webinar series. We appreciate you.
Thank you. And thanks to everyone, and we will stay in touch.